All right, everyone. Well, welcome to the first of a series that we're doing with Specialty Eye in a fall series here of some education that we're putting together. I'm excited for the different education that we're going to be doing. So this evening, we're going to be doing a 2-hour lecture talking about contact lens comfort and the ocular surface. And really, this is kind of a two-part lecture talking about contact lens comfort itself, but also talking about dry eye and the ocular surface. As always, before we get started, I like to give my disclosures here. I have the opportunity to work with a lot of different companies, and we do quite a bit of research here at the Specialty Eye Care Group. And we also have had an opportunity to do some consulting with companies and have an opportunity to share that research and with the work that we do with these companies and through speaking engagements. Specialty Eye Care Group is made up of our dry eye center and well as our primary care center, and then Christy Kading, my wife's practice, the Mind's Eye Center, is our binocular vision therapy practice. And then my consulting company is Kading Consulting, and I also have a company called Optometric Insights. So many of you know that contact lens dry eye is a major issue. Between 50 and 94% of contact lens wearers, depending on the study that you look at, present to their eye care provider with problems related to their contact lenses. That was published in a group of studies. There was a study published in 2013 that looked at all of these different studies. So obviously, if you're a contact lens wearer and you come into a practice, it kind of shows that that you probably have some issues. And you know, when we look at the contact lens practices that are out there, nearly 34% of all patients that are in a practice are contact lens wearers. The vast majority of them are under the age of 42. And when you look at whether contact lenses should really be an aspect of our practices, they should. They make up a substantial component of the finances. In fact, if you compared a spectacle wearer to a contact lens alone wearer, there'll be a 91% increase in profit of a contact lens wearer over a spectacle wearer over a 6-year period. That's a pretty substantial percentage. Now, in any given 1-year period, that may not be the case, but with contact lens fitting and evaluation fees, the rate that a contact lens wearer returns to the office, as well as you know, a patient who's a contact lens wearer will also purchase spectacle lenses from time to time over the course of a 6-year period. In that lifespan of having that contact lens wearer, you'll generate substantially more revenue. Just as a side note, if you have any questions along the way or comments, feel free to put them in the chat section. That's as close as we can get to having a discussion. So please let me know if you have any comments along the way. So when we look at the contact lens industry across the United States, about 39 to 42 million contact lens wearers are present in the US. That is made up primarily of females in a 2 to 1 ratio, 2/3 ratio, females 66% and males making up 34%. So somewhat of a substantial skew towards the female, and that certainly is something that we need to be keeping in mind as we are seeing these patients. Of particular interest, I want to point out this slide here, and this really started to change the paradigm for me when we started looking at our contact lens patients. If you look at the visual demand and who are the people that most need vision correction, it accounts for patients that are over the age of 40, 45. But when you look at the contact lens wearing population, nearly 70% of all contact lens wearers are under the age of 45. It's as if people start into the contact lens wear, but then drop out when they turn 42, 43, 44 years old. And, there's a lot of reasons for that. As I've asked practitioners over the years, what are the top reasons? Different people have different perspectives on what that might be. The contact lens dropout from a year-to-year standpoint remains to be above 18% in almost every study that is done, meaning that nearly 1 in 5 of all the contact lens wearers that are wearing lenses are dropping out every single year. And that poses some significant challenges to us as fitters, asking the question why that is. And is it because their vision isn't as good as they would like it to be, or something else? Well, looking at that very thing and wondering why do people drop out of contact lens wearers, 12% drop out after just 5 to 6 years of wear. And of those that are in this particular study, 50% of them did so because of discomfort, dryness being the second most common in that particular study. Another study looked at about 450 patients, 24 discontinued their contact lens wear in this particular study, and the two reported causes of discomfort that led to discontinuation was dryness and discomfort of their contact lenses. Another survey looking at why did these nearly 200 patients discontinue their contact lenses, 72% reported that discomfort was the number one cause. Now, many people have said, well, if that 40 to 45 year group, that's probably because of vision and they're becoming presbyopic and we just don't have any good multifocal contact lenses. Well, this particular study in 2013 really hit home with that. The top two reasons were discomfort and dryness, fluctuation, blurry vision, discomfort with the quality of vision was way down the line. The top two reasons in this particular study for dropping out were discomfort and dryness. Now, in 2013, a study by the Investigative Ophthalmology was really this TFOS work of why do patients have discomfort with their contact lenses. It was a huge study, a huge group, a huge collaboration, kind of like the TFOS study that we have, the DEWS-2 report or the meibomian gland dysfunction workshop, but this was contact lens discomfort and what are the killers of comfort that patients have and what does that look like. They looked at the progression of what happens for patients who are uncomfortable with their contact lenses and what ends up happening. And I've started to evaluate this as to when I have a contact lens wearer, I try to put them into one of these 5 categories and I add a 6th one. And the 6th one is hasn't entered this yet. And the 6th group is what do I do to keep them from entering into the strugglers category, the physical awareness or the visual disturbances that lenses bring. That then leads to patients have reduced comfortable wearing time where they may remove their contact lenses when they get home from work in the evening, or they end up leading to reduced total wearing time of I need to reduce the lens wear because my eyes just can't handle that. And, this is really a key spot for us to target our patients is when they say, oh yeah, I take my lenses out when I get home at night. And then I've asked my patients, are your lenses uncomfortable? And they say, no, they're not uncomfortable. I just have to take them out at night like everybody does. And it's this perception that, as I get older, my eyes won't be able to wear contact lenses as much, or I'll have problems with my lenses. And that's pretty normal because they talk to other people. Well, that's not normal. That should not happen. The ocular surface should be able to protect and keep a patient comfortable with their lenses. And some of these patients will then say, well, you know, I stopped wearing my lenses on the weekend and I just wear my glasses because it's just easier. Or, you know, I've decided that I wear my glasses because I see better at the computer. And, you know, I just wear my contact lenses to the gym or maybe on the weekends or for special occasions. And then these patients eventually are permanent discontinuation of their lenses. And again, that's over 1 in 5 patients do that every single year. So take your group of contact lens wearers in your practice. Approximately 35%, 1/3 of all patients coming in for a comprehensive eye exam is a contact lens wearer. Take that subgroup, 1 out of every 5 of them, and that's going to be maybe 1 or 2, maybe 3 of your patients every single day that is a contact lens wearer, probably about 1 or 2 patients a day, is going to say, I'm done, no more contact lenses. I've given it a wrap. We've tried them and they're not working. We're done. And that's the cycle that these patients go through. And, you know, historically, we've kind of looked at our contact lens wearers as to what is the cause of them. Back in 2004, 2005, and 6, we really hit hard on contact lens comfort in our industry. This is when silicone hydrogel lenses were really hitting the market hard, and we started to have contact lens solution wars. You may remember back, if you have been practicing this long, to the discussions around acanthamoeba, fusarium outbreaks with certain contact lens solutions. And I was on the lecture circuit. I traveled, I got more miles on the airplane those 2 or 3 years talking about contact lens comfort than probably ever since. And we really were starting to blame contact lens solutions and contact lenses themselves for the comfort that our patients were dealing with. So when it comes to contact lens comfort, we really start to boil that down into a couple areas. Number one, the solutions, which we'll talk about in a moment, but also the contact lens material, the design, the fit, and the wear. So this was kind of from the executive summary of that contact lens discomfort that I was bringing up with the TFOS. We also have environmental issues. These are modifiable patient factors, the medications, the ocular surface issues, and so forth. So I want to kind of dig into each of these different things and how, as clinicians, it's a good idea for us to look very closely at these. This is not something where I, say that we've got it all figured out at Specialty Eye, but it's, on a weekly basis, we get somebody either referred to our practice from one of you, or potentially we get a patient who has found us through the internet that comes in and says, I want to wear contact lenses. I've been struggling. I've worn all of the lenses that are on the market, and they almost know more about the lenses that are on the market than I do. And they just say, there's something not working here, and I really need something to help. It's somewhat embarrassing when I switch their contact lens solution or make a simple fix on the lens design, switching them from XYZ lens to YWP lens, and voila, they tend to have the comfort. So here's a couple things that we've learned over the years. Quite possibly this will be the most instrumental portion of this lecture for you if you have not heard it yet. And this is from research that we had from Pacific University. As many of you know, we're affiliated with them through our residency program, and still are very close friends with the faculty down there, and go down every so often and kind of speak with them about the research we're doing and the research that they're doing. So in 200 consecutive eyes of optometry students, they evaluated the horizontal visual iris diameter. And in this group, we look at the average of 11.8, with an abnormal being 0.5 millimeters on either side of that. And of this group, about 27 had smaller than 11.3 and smaller, and 26 were larger than 12.3. So nearly 1/4, or 53 of the 200, had eyeballs that were larger or smaller. Again, so this is 1 in 4 of the contact lens wearers that are coming into your practice have a lens diameter or corneal diameter that's larger or smaller. Now, if you don't measure HVID regularly, you will miss this. Let me tell you that as arrogant as I have been over the years, it's quite surprising how often when we go to measure HVID and I make an estimation ahead of time and then we go and measure it within our corneal topographer, how surprised I am that we are way off. You can see that you can do this with a ruler here on the left side of the screen, this particular patient having about a 10.5. But when you get into that 12.3, 12.5 range, it's difficult to really be able to kind of identify it being 12.8 plus or minus. But doing it with a manual PD ruler, so to speak, you may be able to do this, but having a topographer or an instrument in the office would really be helpful for you. And if any of you are interested in updating your topographer, we've got some really, really exciting news on corneal topography that I'd love to share with you. Just go ahead and email me at drdave@specialtyi.com. I'm putting it down here in the chat section, drdave@specialtyi.com, and I'd love to introduce you to a couple of different discussions around corneal topography and how to best go about thinking about topography as you move forward in your practice. So HVID tends to be this. Now, it's not necessarily just because the diameter of the cornea is larger or smaller, but what it really boils down to is the sagittal depth of the cornea as a result of this. So for instance, this cornea here has 14 millimeters. This is a soft contact lens central radius and the sagittal depth of 14 millimeter. And you can see that with the different diameters, we have different sagittal heights of the lens. And although the diameter of the lens is exactly the same, the base curve really shifts the depth of that lens. Likewise, if we take a lens that has the same essential base curve of an 8.6, but we alter the diameter of the lens, you can see how the sagittal depth is smaller or shallower. And a cornea that is a lot wider or larger tends to have a lot deeper sagittal depth. So the base curve optical radius here, you can get it from this calculation, the radius of curvature, knowing the chord diameter and then getting the sagittal chord of that lens. So utilizing an instrument here from the Aston University, the Optometric IS-830, the group at Pacific worked with this organization and measured the sagittal depth across most all of the lenses that we have on the market. Now, there's been a couple of lenses that have come out since the research was done, and so they may end up having to update this data, but they looked at the various different sagittal depths of the lenses that are on the market. And here is the daily disposable categorization for the lenses that are on the market. And I bring your attention to a couple novel things here. Number one is I'd like to point out to you the Dailies Aqua Comfort Plus and the ProClear 1-Day lens. That is the blue lens, fourth from the left, and the red lens, fourth from the right. Those two lenses are labeled with exactly the same base curve and exactly the same diameter. These companies have put these base curves and these diameters on the lens, and when it comes to a soft lens, I'm not saying they're doing anything maliciously, but these lenses may actually have some arbitrary aspects to the numbers. We may choose a lens that is an 8.6, thinking that it is going to be steeper than a lens that is an 8.7, when in fact that lens may not be fitting the same way. So keeping that in mind, we can't always trust that the base curve diameter relationship is going to substantially alter how the lens is going to fit. So we've taken this to heart in our practice. You can see the blue is the Alcon, green is the Bausch & Lomb, red CooperVision, and the yellow the Johnson & Johnson lenses. And let's say we've had a patient in the AccuView Oasis one-day lens, and the patient comes in and they say, you know, I've tried this lens, I've tried that one-day AccuView one-day moist lens, and I have to stop wearing contact lenses because they're so uncomfortable. And lo and behold, we measure that patient, and the patient explains to us, no, doctor, I was changed to these daily disposables because they were supposed to be more comfortable than the AccuView Oasis 2-week lens that I was wearing. And so when I switched over, I did not feel an improvement in comfort. I don't really see the point of switching to any other lens. Well, lo and behold, this particular patient has a 12.3 cornea, which is 0.5 millimeters above the average. And we end up switching that patient to the other base curve of the AccuView Oasis, the 8.5 14.3, as opposed to the 9.0 14.3, or switch them to a MyDay lens. And this particular patient noticed a substantial improvement with both of those options over the lenses that they were wearing before, and they were just blown away. I reported back to the clinician that I would recommend the patient buy an annual supply from them of the MyDay lenses or a 8.5 14.3 AccuView Oasis, and they were flabbergasted that simply by making that one change, we were able to so dramatically impact this patient's particular life. So we've taken this particular graph really to heart. Time and time again, when we see those patients with super large corneas or very small corneas, we have gone to this chart, and we have it in all 3 of our offices right by the contact lens cabinet, and we look at the HVID of those patients and we measure it, and then we choose the lens based off of this. Now in our office, we tend to fit mostly Clarity and BioTrue lenses, and they work for most all of our patients. And I don't say that because, you know, those lenses are the best lenses out there, but they are right smack dab in the middle of these charts. And then when a patient reports that they're having problems measuring their HVID, tells us which direction to go. So it works very well. Here is what this particular graph looks like for lenses that are reusable. And you can see a substantial difference between the Air Optics 13.886 lens versus, say, the Frequency 55. There is about 700 microns of difference between those 2 lenses. And I assure you, there is a huge difference in how these lenses fit on the eye. And again, that somewhat arbitrary number of the toricity. For instance, in this graph, the Clarity one-day lens, 3rd from the left, and the MyDay toric, 4th from the right, both lenses made by CooperVision, both labeled as 8.6, 14.3. This company's sagittal depth between those 2 lenses is nearly 500 to 600 microns difference, and the lenses are labeled with exactly the same sagittal depth. So look closely at that. Now, this particular patient comes into the office, and as you can see, they're a little bit frustrated about the discomfort of their eyes. And we look at this lens. This is a 2-week lens that has been worn for 5 or 6 weeks, or this may be a monthly disposable lens that is being worn for a monthly or a 6-week time period. And the patient says, you know, my lenses are uncomfortable after I get to the 3, 4, 5-week time period. And they're always feeling more comfortable when I first put them in. Why is that? Well, one of the biggest reasons that we have to always be reminding our patients is the importance of hand washing. Healthy hand washing habits are so critical to what's happening. You can see the coliforming units of patients who have unwashed hands to washed hands, and then if they dry them, they again reduce those microorganisms by about a threefold factor. And when we do wash our hands, and of course we now wash our hands far better because of COVID, and each of us has these little things on our tabletops and all around the office. But you know, before that, we had major issues with our contact lenses dirtiness because we weren't washing our hands very well. Well, another factor with our contact lens wearers is this is not a reliable source for cleaning our hands because it has alcohol in it, and alcohol can obviously do a whopper to the surface of any contact lens. One other thing that we fail to remember so often is the importance of our contact lens case for patients who are utilizing a monthly disposable or a 2-week disposable lens or a GP lens wearer. In one study, 70% of all of the cases that were observed were contaminated. And when they looked at it, the bacteria was showing up within 7 days after a case replacement. So lenses cases need to be evaluated. What's ending up happening is within these cases, there's this exopolysaccharide glycocalyx biofilm, which is, just kind of think of this jelly that coats the surface of the lens. It's of course microscopic, and what we've seen happen in the 2006 and 2007 epidemics of Acanthamoeba and Fusarium was that when patients would top off their solution, the chemical killing aspects of the solution would be absorbed into this jelly, this exopolysaccharide glycocalyx biofilm, and the lens solution became less effective at killing the bugs on the contact lens. That particularly was one of the major issues for the recall that needed to be done for solutions. And so they ended up going ahead and removing that lens from the market. But we came to realize the importance of case replacement. In fact, our cases should be replaced about once a month. When looking at a study, you can see the number of people who never replace their case. They've come into my office as a first-time wearer. We don't let them do this after that. As a first-time wearer, having the same contact lens case for the last 3 decades. They've gone through 3 or 4 marriages during that time period, but they still have the same contact lens case. And then they go to tell you why it's the best case in the world, and then you say, no, we're throwing it away. So contact lens cases should really be replaced on a monthly basis. And when patients are removing their contact lenses and putting them in their eye, the case should be dumped out, rinsed with solution, and then air dried. And that's the best way we know to be able to help keep a case healthy. So now let's talk about solutions for a little while. And again, we haven't talked about contact lens solutions for nearly a decade. Contact lens solutions really were a big thing back in the early 2000s, but we haven't had really a contact lens solution released into the market in over a decade for the most part. And if you look at contact lens solutions that are on the market, we need to have this pH of about a 7. In all solutions, there needs to be a buffer, a viscosity agent, antimicrobial components, surfactants, as well as stabilizers in the solution. Mix all this together and you're going to have something that's really healthy for the ocular surface, right? Just geniuses are the ones who come up with these solutions. And Ralph Stone is a chemist that has worked for Alcon most recently, and his knowledge on solutions and what he has taught me on solutions is just astounding. I'll never be able to fully understand how contact lens solutions are so compatible. But the reality is it's still a chemical. and our patients are going to the drugstores and they're picking the solution based upon that little yellow tag as opposed to the solution itself. The generics are still widely utilized by our patients. And so we have to keep this in mind when we are dealing with solutions. This whole no rub epidemic that happened for a while, where we told our patients they didn't have to rub their lenses, really shot us in the foot from a comfort perspective. We don't talk about that very much anymore, but it's so critical that our patients take care of their lenses the right way. In this particular study that was put out looking at how patients do take care of their lenses, in fact, 52% of all patients take their lenses out and remove them and initially just go for a dunk. This was a study that was published over a decade ago. And without contact lens solution manufacturers reminding us and us having contact lens solution reps coming into the office, I bet you it has been nearly a decade for most of us since we've even talked about solutions with our patients. Now, we've switched over to dailies in our office, and so that's really rarely a conversation. But when somebody does come in with a monthly or quarterly replacement because of the prescription power, it needs to be something we talk about of how to clean the lenses. Only about 16% of all patients are rubbing, rinsing, and soaking their lenses appropriately. And 4% are doing something other than rubbing, rinsing, or soaking. I don't know what that is. So what about the replacement of the lenses? A study looked at this as well in 2016, 17, and 18, and we see that compliance with daily disposables far outweighs that of any other lens type, monthly being the second, and quarterly actually even being more than 1 or 2 week. So we asked that question to a lot of patients, and I've researched this across the country as I've talked to practitioners as well, is what's the number one reason why patients aren't replacing their lenses like we asked them to? And most practitioners say, well, the patient's just trying to save money. Well, in fact, the study showed that 51% of all patients simply forgot the day that they were supposed to be replacing their lenses. They just wore them 3, 4, or 5 weeks instead of 2 weeks, or 5 or 6 weeks instead of 4 weeks. Saving money is still a percentage of the population. And what really struck me is that some of them don't replace their lenses like they're supposed to because their eye care provider told them. Well, about 12 years ago in our practice, we asked the providers this question. What's the healthiest way a patient can wear a lens? 2 week, 1 month, or a daily? I had to ask myself that question too. And of course, I knew the answer was daily disposable. And then we just as a practice decided, if daily disposables are the healthiest way to wear lenses, let's move all of our patients into daily disposables. So for the past decade, I've been lecturing and doing that, and we started moving our population from about 40% daily disposables, and now we're at over 90% are daily disposables. And over the years, we have seen some improvement in the daily disposable market. As most of you know, these brand new lens types are coming out constantly. Looking at this slide, I already see that I've missed a couple of the newer lenses that have come out since I haven't updated this particular slide today. And we look at what's happened to the market since over the last decade. Monthly disposable lenses have not really changed a whole lot, but Vistakon, particularly Johnson & Johnson, has really started marketing their daily disposable and less on their 2 week. 2 weeks still substantially a high percentage at 21%. But daily disposables and 2 week lenses have nearly switched places, with dailies accounting for about 40% of the total marketplace here. Back in 2018, we still had a higher percentage of patients using month or quarterly lenses as well. So why are more single-use lenses not used in the United States? And this has been a question I've asked practitioners as I've pressed them on this, and cost is always the reason why practitioners list is that they're not fitting more lenses. And I have to say to them that the reason why that is that when it comes to cost, practitioners are really advocating for non-compliance from their patients. In fact, in some cases, they're promoting non-compliance. And I don't think that we always are actively promoting non-compliance, but if cost is the reason why you do not fit a daily disposable lens, then you're not fully looking at the entire picture. Here's the picture that you are missing. If you are recommending your patients clean their lenses the way they really should be cleaned, and I personally think that we should take the recommendations of the manufacturers or even go above what the manufacturers are recommending. I took the OptiFree Pure Moist and the BioTrue lenses, opened the package, and looked here at the directions. In this particular case, rub 20 seconds on each side of the lens, thoroughly rinse each side of the lens for 5 seconds. So just to point out what that would look like, let's rinse one lens. That's 10 seconds. So thoroughly rinsing to me means a steady stream of solution. So we're rinsing with a steady stream of solution for 10 seconds. That was 10 seconds of rinsing the contact lens with a steady stream of solution after we have gently rubbed the surface of the lens for 20 seconds. Now, are you telling your patients to do that? If you're not telling them to do that, then they're not getting their lenses clean or as healthy as they should be. If you do what the recommendation says, the patient, and if you look over at the OptiFree side, on the left at the very bottom, it says rinse each side of the lens for 10 seconds. So now we're doubling what the BioTrue is recommending here. And these patients are going through more than 3 bottles a year. I say 3 bottles a year because that's the average number of bottles that a patient goes through in a year is 3 bottles. That indicates that they're not doing what they should be doing, and quite possibly you are promoting that. If we're not advocating for them to rinse their lenses the way that they should, then we're somewhat promoting it. So telling your patients to do it this way will indicate that a patient will likely be spending far more than 3 bottles, quite possibly 10 to 20 to 30 bottles of solution, give or take $10 each. That's about $200 to $300 to $400 a year on contact lens solution. Added to the cost of the lens, we're over the cost of a daily disposable lens. So either we are non-advocating for our patients' health, or we advocate for our patients' health and give them a lens that's less expensive, and that would be a daily disposable. People say, well, I don't think that's really realistic or really doable. This is a report from, I'm not sure when it was, but it was year to date for the contact lenses that we had been using in our practice. This is using Glimpse, which is an ABB software. I'd be happy to kind of describe or show you how to use Glimpse someday. But we were at this point, we had done 1,029 boxes of daily disposables compared to 56 monthly and 4 2-week. And you look at that comparatively to where the national average is, you can see that we were way more with our daily disposables, 94% at this point in the year. I'm not really sure. And looking over at that numbers, it looks like we were even down compared to the year before in the lenses that we were using. So you can do this. It has to be a state of mind. It has to be something you are adamant about. And knowing that the surface health of my patient's eyes is at risk, we really focus in on that. So much so that when a patient comes in and is adamant about saving money, that tells me that they're not going to be using their lenses the way that they're supposed to. And that tells me that the patient is not taking my recommendations. And whether the patient has glaucoma, the patient has, a visual field, pie on the floor, pie in the sky, which we actually had today in the clinic, they're not going to take my recommendations. And I don't want to be affiliated with that patient. I'm a little bit concerned about what their other things are going to be doing. And so I work to help that patient along to find a doctor who may be able to help them the way that they want, which is seeing them for exactly the way that they want, doing what they want. Really, when we look at the ocular surface is made up of a lot of components. And in order for us to keep the ocular surface compatible with the contact lens, we need to disrupt this ocular surface as little as possible. With the contact lenses that we put on the eye, they've been shown to decrease the tear volume, the non-invasive tear breakup time. 85% of contact lens wearers have less than a 10-second breakup time. That really tells us that we are disrupting the ocular surface. Contact lenses have also been shown to decrease the stability, the thickness of the tears, and then increase tear evaporation. So it's kind of a doomsday thing here when it comes to contact lenses on the ocular surface. And the reality is that we should have an ocular surface that is robust enough to be able to handle long-term contact lens wear. Contact lens would be classified as something that causes desiccating stress on the ocular surface, similarly to a patient having some wind blowing in their eye. And anything we can do to boost that patient's the effect of a contact lens on the eye, whether it be reduced wearing time, artificial tear use over the top of a contact lens, whether it is having the patient utilize a daily disposable lens, which doesn't cause as much damage, reducing contact lens solution use, getting them into a daily disposable. All of those sort of things are going to really advance this complicated ocular surface that we see here that our patients are encountering. So in ending of this contact lens component of this lecture, I really would advocate for you to be thinking about what are the products, what are the things that are out there that are most boosting the tear film and the tear quality for my patients. We decided that the F word in our practice was fine. When patients say, my contact lenses are fine, that's a four-letter word to us, and we no longer advocate for that. We look for patients who say they wear their contact lenses comfortably all the time. If they say that sometimes they forget to take them out, we give them a thumbs up and then tell them, hey, you got to figure out a way to make sure you take your lenses out when you go to sleep. And we're looking for that 35-year-old patient who is starting to notice that they feel their lenses sometimes. Remember that breakout group as we were looking at the 6 categories, 5 that were on the screen, the strugglers. If you see somebody in that category, or you see somebody who is fine with their lenses and they're utilizing a lens that is a older technology, a monthly or a 2-week disposable, then boom, advocate for that patient to get into a better product. And I'd recommend going into any of the daily disposables that are available. We're a big advocate of the silicone hydrogel lenses, and we're certainly an advocate of the lenses that have an enhanced ocular surface, the Alcon Precision, the Bausch & Lomb BioTrue, and particularly the Dailies Total One and the Bausch & Lomb Infuse. Some particular practitioners say, well, those are elite lenses. They're only used as problem solvers. Well, here's the deal, my friends. My patients are all elite. And maybe they don't have the funds to get these, and that's okay, and we can find an alternative. But I'm going to try these lenses on every single patient. We've actually made a commitment that we are going to, since the infused lens has recently come out, we are going to work to get all of our patients to try that lens and see how they deal with it. I'm not the one that's in charge of the pocketbook of my patients. So I'll share with them. It's a little more expensive than the other daily lens because 95% of our patients are in daily lenses. It may be a more expensive lens than the ones that they're wearing, but there are rebates and there are other advantages. And if you look at that cost per day, it's not a substantial increase. Now, if a patient cannot be in a spherical lens like this, we're going to put them into a toric or a multifocal lens in the MyDay or in the BioTrue or Dailies multifocal, Dailies Total One multifocal, and really work to boost that ocular surface with the contact lens. And if for some reason they have a high cylinder or they have an axis that's 45 with 2.25 or 275 sill, and they can't be in a daily disposable, or they're a multifocal toric patient, they could go into a Biofinity multifocal toric or a ultra multifocal toric. We would end up using a clear care type of solution, which really reduces the chemical toxicity that is going on in the eye. There are some patients who need to be into a solution that is a multi-purpose, but for the most part, we're going to try to get them into a peroxide-based solution. So with that, we will convert over into the dry eye discussion. And let me just take a peek over here at the chat. For any of you that are here, we've got 96 participants on the panel, and I do not see any questions. So either you are all sleeping, or you're watching television, or you are just not needing any clarification on anything. Let me just take a drink here. So let's talk about dry eye. Now, I've had this interesting relationship with dry eye over the years. I finished my residency in contact lenses in 2004, and we started becoming experts in contact lenses and in all things. And I remember seeing this 18 to 20% dropout, and I lectured about that dropout with new contact lens solutions and new contact lens materials that were coming out. And each time we presented on contact lens solutions and materials, we talked about reducing the contact lens dropout rate. Well, fast forward 5, 10 years, the contact lens dropout rate did not change. With new lens technology and new lens solutions, we were still dealing with the same problem of these patients having contact lens discomfort. And as a practice who sees all of your specialty contact lens patients, those of you who graciously trust us with your keratoconus and your graft patients and your post-RK patients and your patients who are just fed up with contact lenses, and we get to see them. For those of you who are referring, I just couldn't handle those patients dropping out of their contact lenses, keratoconus and whatnot, because their eyes were dry. And we were trying different lens types and different solutions. And I just came to this realization: as I lecture across the world, I'm giving the same presentation as everybody else about lens improvement, and we're getting nowhere with this number. And then I took a hard look at our own patient base, and we were having the same level of dropout. So I pulled back and I said, we're doing something wrong here. We need to evaluate dry eye in a new way, and we need to start thinking about dry eye as being the cause of contact lens comfort first, and then work on the lenses. And it really hit me with this really stupid question. And that was, if my patients were comfortable in their contact lenses a year ago, Wearing the same lens and the same solution a year later, they're uncomfortable. Did anything change to the lens or the solution? And if the answer was no, then my advocacy to switch to a new lens or a new solution would only push them along this channel where their ocular surface was not supporting their lenses. So that just struck me as like, why didn't I realize that earlier? And as I've talked to clinicians around the country, they've asked the same question, and they said, well, I guess maybe it is the ocular surface and it is dry eye. And we came to this discussion around, well, what is dry eye? And, somebody would say, well, it's when, the patients feel like they have dryness. That's when they have dry eye. And I said, well, what if they have corneal staining and they don't have any symptoms? Is that dry eye? And they say, oh, yeah, that's dry eye too. Well, is it symptoms or is it signs? Is it decreased tear breakup time? What is dry eye? And we look at the TFOS, the DEWS 2 report for a categorization of what dry eye is. And those definitions just get more and more complicated. So I started talking to some of my mentors about what do they consider dry eye to be, because I'm a clinician. Although I do lots of research, I get referred your patients. I get referred patients from, several different places around the Pacific Northwest for dry eye. And I needed to come up with a definition that I could grab onto and I could say yes or no. Yes, dry eye, something else. And my mentor gave me this definition that we've worked with for the last couple of years, is when the ocular surface system fails to protect itself from desiccating stress. If you can answer that the ocular surface system is protecting itself from desiccating stress, they don't have dry eye. But if for some reason the ocular surface system, lids, conjunctiva, cornea, eyelids, eyelashes, eyelid margins, palpebral bulbar conjunctiva, puncta, if that system is no longer protecting itself from desiccating stress, then the patient has dry eye. Well, desiccating stress, I'll show you here in a minute, has many different names or many different causes. But when I walk into the room and I look at a patient's eye, I'm looking for a disruption to the ocular surface system of some sort. Sometimes I don't see anything, but I hear symptoms. Sometimes I hear no symptoms, but I see that there is a disruption to the ocular surface system, such as this patient. If you have not instilled lissamine green on your contact lens wearers, I propose to you to try something. For the next 10 contact lens wearers that you have, put a strip of lissamine green into their eyes, whether they have symptoms or not. And if one of your patients has this, I will be surprised. Of the 10, I will bet you that at least 3, if not 4, of your contact lens wearers have this appearance around the cornea. And what's happening here is there's a desiccating stress on this eye. There is a contact lens on the surface of this eye, and it is causing stress upon the ocular surface. And this patient's ocular surface system is failing to protect itself from desiccating stress. And there is conjunctival staining, which is caused by the goblet cell disruption. And we end up seeing this conjunctival disruption. Now, goblet cells are on the cornea too, and if you do not do some sort of intervention for this particular patient, I can give you nearly a guarantee, this is medicine, so there's no guarantee, that this patient will come back and see you 1 or 2 years later with discomfort on their eye. I can tell you for sure this patient's probably uncomfortable because of that Mark's line staining and that lid wiper epitheliopathy on the lower lid as well, where there's an incredible amount of friction. Another sign that there is desiccating stress. But this particular patient that you're looking at right here, Her name is Jennifer, and she's been a long-term contact lens wearer in my practice. Has been wearing daily disposables for the last year, and she came in and she's like, "Doc, these are great, very comfortable, way better than the lenses I used to wear. I'm really glad I switched." And I said, "I've got some bad news for you. What's been going on in your life?" And she said, "Well, I've had a little bit more stress at work, and I started taking some new medications, and bingo, her ocular surface system is failing to protect itself from desiccating stress." And we bring up how we are going to really ask the questions and boil it down to dry eye disease or not. And are the tears quality? Are they getting worse? And if the answer to either of those questions is the tears are no longer quality or the tears are getting worse, then intervention is absolutely required. I say this, probably preaching to the choir here with the 96 of you that are listening, but if artificial tears are your go-to for these questions, you are not intervening to alter the ocular surface. All you are doing is putting ice on a fire. It may calm it down for a period of time, but you're doing nothing to stop the progression. And we look at this really from a symptomatic standpoint most of the time. But dry eye disease is a disease of dysfunction. And if there is progression, we still need to intervene. Diabetes, we don't look at symptoms. We don't look at symptoms for glaucoma or macular degeneration, but we guide our treatments in dry eye based upon how the patient's feeling. And that's the worst things that we can do. In fact, we looked at this very thing and published a poster where we looked at the dry eye symptoms that patients were experiencing with regards to ocular inflammation. And we came to some really interesting conclusions that our results indicate the dry eye symptoms measured by the SPEED questionnaire don't correlate with elevated inflammatory levels, indicating that clinicians should not rely on symptoms alone. We were looking at inflammatory markers and that the symptoms that were correlated with them, and far more patients had inflammation than had symptoms of it. Now, some people wait, we're not going to treat dry eye patients if they don't have symptoms. Well, here's the deal. Why wait until they have symptoms to fix the problem, right? If somebody's got a major issue with diabetes, we're not going to wait until they, start having issues with their feet or their eyes before we start treating their diabetes. Why would we wait until a patient has symptoms if there are problems? And the reality is within dry eye, it's a disease of the nerves. And we ask the question is, does symptomatic relief mean that there is success? And does success always equal symptomatic relief? You see, within the nerves, and pain specialists will tell you that you can't trust the improvement of pain to indicate that there is improvement. The nerve system, it may be completely resolved and healed, and the nerves still may continue to fire. And that's the reality of what we know that happens with so many people. And the nerve system is untrustworthy when it comes to having a patient that has corneal staining and no symptoms at all. So are you going to trust it there? And are you going to trust it on the flip side? So the DEWS 2 report came out with a very complicated definition of dry eye. The three things that were somewhat new to them that really kind of pointed to what we were pointing towards was inflammation and damage, tear film instability, and neurosensory abnormalities. The nerve system really plays a huge part into the innervation of the lacrimal gland and innervation to the meibomian glands. This is what's called the vicious cycle of dry eye. And if you haven't looked this up, take a screenshot right here or look this up on the internet. The vicious cycle of dry eye, with its many desiccating stresses that impose damage upon the ocular surface, start the process at the top, usually tear film instability, imbalance, hyperosmolarity, apoptosis, inflammation, which leads to goblet cell loss. There's also within this cycle and it doesn't have to be started by one or the other. It's actually the chicken and the egg. Both tear film instability causes meibomian gland dysfunction. The studies also indicate that meibomian gland dysfunction caused tear film instability. It goes both ways. They take a group of mice who have normal meibomian glands and you put them into a super dehydrating chamber, and it causes an incredible amount of desiccating stress to the tear film, and it makes their meibomian glands start to atrophy. So desiccating stress causes meibomian gland damage just as much as meibomian gland damage causes instability to the tear film. Our conclusions after looking at things for years and years and years was that really dry eye has to be simplified. If it's not simplified, then you and me in the exam room are unable to treat it. I bought every single piece of equipment that was out there to do dry eye. We spent over $100,000 setting up our dry eye clinic back in about 2011. And since then, what we have been doing is research on how do we not have to use all of this instruments? How do we go about simplifying the dry eye process so that we can really knock this out of the park? And we came up to, there's two causes of dry eye, lacrimal and meibomian gland dysfunction. Two questions we have to ask is the lacrimal functional unit, or the LFU, functioning correctly? And are the glands functioning correctly? And we've come to the conclusion that if we were on the desert island with the hundreds of thousands of dollars of equipment that we have, we would boil it down to these two instruments as being the real cat and, the real cat's meow with regards to diagnosing dry eye. If you have a lissamine green strip, you can diagnose the lacrimal dysfunction. And if you have a meibomian gland expressor, you can diagnose accurately MGD. Now, I'm going to say that I am oversimplifying this on purpose. The reason why is because the majority of the patients that are referred to us started their dry eye process 5 or 10 years before I saw them, and they were not managed appropriately for the 5 or 10 years before. And then I became the hero because at their moderate to advanced stage, we started intervening aggressively. But with the patients that are coming in for their normal eye exams with us, we're treating them mild dry eye very aggressively and preventing them from becoming like the patients that are on disability that are referred to us. And we only have to use the meibomian gland expressor and the lacrimal detection with a lissamine strip. So the question number one is there a lacrimal dysfunction? Lacrimal dysfunction is clearly defined that the meibomian gland, that the lacrimal gland, as well as the lacrimal system as defined in the literature as being everything except the meibomian glands, the goblet cells, and so forth, is not working appropriately. You can see here several areas of staining that we might see, from conjunctival to corneal staining to lid staining. If this is happening, desiccating stress is causing the ocular surface system to be disrupted. We also look at the tear volume, whether it's elevated or decreased, and if there is any levels of inflammation. If there is levels of inflammation, we're usually measuring that in our practice with the inflammatory test from Quidel, finding out if there is even a small amount of inflammation. And we did a study in our practice looking at this very thing, identifying that a substantial percentage of subjects over the age of 40 and older tested positive. 72% of all the subjects that were over the age of 70, they were coming in for an eye exam or glaucoma visit or regular office visit. They were in the general population, about 60% of the patients had some level, 63% had some level of positive as a whole for the population. So inflammation is way more prevalent than you and I think. Tear volume, we can measure that with our Medmont topographer. We can use a Schirmer's test to measure this. And really what we're boiling down to is there a lacrimal dysfunction? The way you know that the lacrimal functional unit is dysfunctional is very simple. 3 things. Inflammation is measured by inflammatory or redness. tear volume being either elevated or decreased. You can look at it with the tear meniscus height or measure it with your Medmont topographer, or if you have an OCT, or if there is any amount of staining on the cornea or conjunctiva. If those are present, barring a foreign body, if those are present, the patient has a lacrimal dysfunction and must be treated. Next, we ask the question about the meibomian glands. Is there a meibomian gland dysfunction? Now, I've looked at this very closely as well as what is a meibomian gland dysfunction. If we looked at this eyelid right here, I think most of us would agree that there is a dysfunction of some sort, but some of us, if I asked you, well, how do you know? Some of you would say, well, there's redness or the capped glands. Some of you might say, well, what's the tear breakup time? Some of you might say, well, the patient's symptomatic, or look at that scurf on the eyelids. That indicates that there is MGD. But that's not a good way to diagnose MGD. Really, what we want to know is, well, what if the eyelid was clean? There was no scurf, there was no redness? What if the meibomian glands looked normal? What if the tear breakup time was normal? Does that patient have MGD? Well, I kind of start to get questioned on this when this paper came out looking at something called non-obvious obstructive meibomian gland dysfunction. It's another type of MGD. We asked the question, well, what defines something as MGD? And are we defining it the same way as everybody else, or is there some way that we can better diagnose this? And what would really be the cause? Well, we've come to realize, and my mentor, Dr. Don Korb, has pointed out that about 90% of all MGD is caused because of an improper blink. You look at these patients here, that the video, you see that they're not blinking all the way and their eyelids are not closing. When you look at the anatomy of the meibomian glands, right at the surface, what we see is the orbicularis muscle squeezes upon the glands and they push upon the tarsal plate. And in a lower eyelid, in an upward fashion against the globe, in an upward fashion, they're pushing and creating a pressure, a positive pressure on the acini, which are those little pods, into the central duct to push oil up towards the surface of the eye. But it's when the eyelids are touching each other that the Ryland's muscle opens and oil is secreted onto the ocular surface. And if oil is secreted into the ocular surface through this manner, and it is a liquefied form, then a gland is functioning in its normal sense. So if we know what meibomian gland function is, and that is when the eyelids touch each other and the patient is blinking in a normal way, that oil secretions that are liquid come out, we now have a way to identify what meibomian gland dysfunction is. And utilizing a calibrated device, meibomian gland expressor, to exert the same amount of pressure upon the eyelid that a patient has when they normally blink, if we see that there are 10 of the 15 glands, 5 glands, 5 glands, 5 glands going across, if we see that there are 10 or more meibomian glands yielding a liquid secretion, then this patient is in the clear. If there is 6 to 10 glands flowing, then this patient is kind of in the questionable stage, kind of like an ocular hypertension. If something else is going on, we need to intervene. If there are 5 or 6 glands or less flowing, that indicates that a patient has a meibomian gland dysfunction. Now, let me give you a little hint. When I do this on a patient, it's usually that there are 2 or 3 glands flowing, or there's 15. Rarely do I count 8. So that yellow range really rarely happens. It's either that there are glands flowing or there are not glands flowing. And it helps me answer the question of a yes or a no. In fact, we did a study in our patient base looking at our dry eye patients, the people who are coming into our clinic for dry eye. And we looked at our numbers. We went back and looked at our meibomian gland secretion scores, and we identified that 78% of our patients that were being treated for dry eye that hadn't had LipiFlow had 78% had less than 5 meibomian glands yielding a liquid secretion, and therefore would be diagnosed with MGD. The problem with this is if you ignore this, the problem is that whether we look at a more traditional thought process about this, or there is another doctor named Jasper who's really hypothesized some work on this, that if a gland is not flowing, then the gland atrophies, then the glands will atrophy. And we start to see this process of gland loss going on. And we look at this from a contact lens perspective. The meibomian glands of a 25 to 40-year-old soft contact lens wearer appeared similar to that of almost a 60 to 70-year-old patient base. Association of gland atrophy, as published by Andrew Pucker, who I've had the pleasure of lecturing with, a fantastic researcher at the University of Alabama. Positive association between a high MIBA score and being a contact lens wearer. And he kind of concluded, and as any researcher would, is that contact lenses could produce negative effects on the meibomian glands through mechanical interactions with the eyelid by altering that natural blink. And we believe that the blink is highly associated, or through some other potential mechanism that we have yet to be discovered. But we know when there is desiccating stress, the meibomian glands, without contact lens wearers, the meibomian glands become affected. And if contact lenses are affecting the contact lens, the blink rate or the blink quality, then likewise. Here's another study looking at this, and contact lens wearers associated with reduced meibomian gland morphology. What they identified is that the damage tends to happen within the first 2 years. And then we don't really see a whole lot of changes beyond that. So really most of the damage occurs within the first 2 years of contact lens wear. And if you cycle us way back to the beginning of this lecture, when do most patients drop out of contact lens wear? A substantial percentage of them drop out within that first 2 years. Now, if we don't have the meibomian gland secretions the way that we should, we're going to have an increase in friction. As you can see here from these interferometry, on the left, having a good oil secretion scores, on the left, not so good oils. You can see that if the eyelid is blinking across this, then there is going to be some issues with friction, and highly correlated with something that is called lid wiper epitheliopathy. We did an evaluation in our practice looking at the impact of soft contact lenses on the lipid layer thickness, and what we identified is that the lipid layer thickness went down in its total average score over the course of a patient's wearing time, utilizing some of these fantastic contact lenses that were out there. And if that is going to be happening and we're going to see those frictions, we're going to end up identifying something called lid wiper epitheliopathy. Just think about the eyelid sliding across a thinner lipid layer or a thinner tear film and having friction. That is going to eventually cause some irritation to the eyelid margin called lid wiper epitheliopathy. And in several studies, I'm going to show you 3, 2002, 2005. In this 2002, 80% of patients were symptomatic for contact lens dryness if they had lid wiper epitheliopathy. Study done in 2005 found 76 rather than 80% of patients with lid wiper epitheliopathy were symptomatic for dryness. And in this particular study, looking at dry eye patients, not necessarily contact lens wearing patients, 88% of lid wiper was seen in the symptomatic group, 16% of lid wiper in the asymptomatic group. So lid wiper epitheliopathy is 6 times greater in dry eye disease patients. 16, if there's grade 2 lid wiper epitheliopathy, which what I showed you was grade 3, there's grade 2 or more lid wiper, there's a 16 times greater probability that that patient is going to have dry eye disease. My friends, some of you are utilizing to your breakup time as your primary indicator for dry eye. Some of you are utilizing corneal staining. Some of you may be doing osmolarity. Some of you may be, I don't know what you're doing, looking at tear volume with the Schirmer. If you want to see a correlation between what patients are feeling and what patients are saying, lid wiper epitheliopathy is the highest correlation that I have seen. And if you look at these studies, it really points to it. 80% of the patients that had lid wiper epitheliopathy had symptoms. And if you find a patient has lid wiper epitheliopathy without symptoms, only 16%, a patient may go on to develop symptoms. It's also a good way in a nonverbal patient or a patient that doesn't speak English or you don't speak their language of knowing what they're really dealing with here. Lots of different technologies that are available. Utilizing a device like the Keratograph 5, or there's a new device, a new topographer that we're starting to work with a little bit more from Medmont, and I'd love to tell you all a little bit about it. So when we look at this particular group of technologies that are out there, you kind of wonder, like, well, which should I use? Well, and it comes down to diagnosis. If you are not specializing in these two devices, you're probably missing a lot of dry eye. Corneal staining, lid wiper epitheliopathy, you're looking for tear volume and inflammation, indicating lacrimal dysfunction. You're indicating meibomian gland dysfunction if you have 5 or fewer meibomian glands yielding a liquid secretion. So come up with some sort of a protocol based upon what you see with each of the patient's eyes. So let's talk about treatments for a second. And this is the case with contact lens wearers or non-contact lens wearers. The number one treatment we can do for our patients is blink therapy. As you can see here, these patients all went through blink therapy. These top 2 patients, and they had therapy, and at the bottom you can see their blink improved substantially. Simply having your patients do 60 seconds of blinking every single day. I do it 10 seconds at a time, split up six times throughout the day, or 2 30 seconds increments where they're just acknowledging that they're blinking, knowing their eyes are closing, just like I'm doing here, will make a substantial improvement upon their eyes. And then the other thing that we do is equivalent to a dentist telling somebody to brush their teeth. It's these things right here: warm compresses, omega-3s, lid scrubs, and an artificial tear that matches the condition that the patient has. We found Refresh Advanced being a good overall, or Sustain Complete being a good overall tear film. Now, many of us are utilizing steroids. Steroids are a great way to kind of kickstart the whole process. But steroids don't do anything long-term. That vicious cycle I was telling you about, they have been proven to stop the vicious cycle. But then when a patient goes off of the steroids, the vicious cycle starts back up because there's nothing controlling that vicious cycle long-term. So my friends, if you see corneal staining, an alteration of the tear volume, if you see that there is any type of inflammation in the eye and staining or tear volume, the patient needs to be on a prescription medication which will alter how their lacrimal gland is functioning. In mild cases, potentially you can get that benefit from an omega-3. But in almost all the cases, the literature is very clear to us that a patient that has a lacrimal dysfunction, good friend of mine, I'm calling him a good friend. He might not think so, but I think he's a genius. Michael Stearns, his literature is so good to read. He's an immunologist. Michael Stearns brought about and helped us understood that the lacrimal gland is in an autoimmune type of disease once it becomes activated. And that's why dry eye disease is a disease. It's chronic and progressive. Utilizing an artificial tear is putting ice in a boiling water. It's going to continue to boil. But what these medications are doing is they're slowly turning down the boiling hot water. Well, what about patients? They don't feel the improvement. Well, that's not why we're treating it. The patient has a disease, and we got to turn down that volume. So I tell my patients, just like a high blood pressure medication helping you to not have a heart attack, just like a thyroid medication altering the effects of your thyroid, these drops are intended for that purpose and that purpose only. While many patients feel an improvement, we don't ever focus on that. We focus on these patients improving the health of their eye long term. So they go on these medications and they do not stop them. It's easy to say. It's a little bit more difficult to get patients to use them. But the reality is, when the first thing that I'm going to do to any of the patients that you refer to me, I'm going to put them on one of these medications long term and explain to them why. The other thing is this lacrimal dysfunction, and what's really going on with the patients long term with the meibomian gland dysfunction. And when we think about meibomian gland dysfunction, we're really trying to target getting a gland to go from no flow to more flow, less flow to more flow. And LipiFlow has been very, very effective at doing that. And the research that is out there, which says a 3 times improvement in gland improvement, 2 times improvement in the symptoms. In fact, about 91% of patients feel an improvement. We don't care about the symptoms, right? Because we don't know what corneal nerves are doing. Improvements are seen well beyond 9 months. A lot of studies are 3 years out, safe, well-researched. I had the fortunate opportunity to be part of this particular study looking at contact lens wearers utilizing LipiFlow. And what we did is we researched and we looked for patients who were unable to comfortably wear their contact lenses 8 hours a day, but they still did. They had to wear their contact lenses at least 8 hours a day, but they had to be miserable in doing it. And as you can see here, the group that is in the black, after 1 month, we looked at the secretion scores in these patients. We doubled their secretion scores from 8 to 20, and that stayed there at 3 months. We took the baseline group, which was about the same secretion scores. They didn't get any treatment, but at 3 months, they got a treatment, and they showed a substantial improvement as well in their secretion scores. But what was even more impactful was the symptoms that these patients had. Higher number is worse. So you can see that we improved the symptom scores by half. We reduced the problems that they were having by half, and it got better at 3 months than at 1 month. And then the group that ended up going to 3 months, we did their treatment at 3 months, and we improved their symptom score by a little more than half. And so, considerable improvement for these patients. But for me as a contact lens provider, I wanted to know, well, what about contact lens wearing time? These patients were uncomfortable with their contact lens. The mean comfortable wearing time was about 4 hours. After they had had a treatment with LipiFlow, the group that was uncomfortable reported their comfortable wearing time of 9 hours. And at 3 months, you can see the group that was untreated did not show an improvement. Now, there's other things that are out there besides LipiFlow, so I don't want to seem like I'm partial to just LipiFlow, but I really look for the studies that are out there that show that a patient has gone from no flow to flow. We just are wrapping up a study on the iLux comparing to LipiFlow. And so I don't have all of the data from that study. In fact, today the investigator is in the office collecting the final data. So we haven't got that information ready to publish. But in the studies that are shorter term, this was a 1-year study that we took part in, but in the shorter data, we showed that patients had an equivalency with iLux as they did with LipiFlow. And so this is a potential treatment. Now, if you look at the costs of these two treatments, they're about the same. Your cost as a practitioner is about the same. You may buy the device a little bit less for the iLux, and it's handheld, so it's a little easier to manipulate around the patients. But you or somebody skilled has to be the one doing it. The LipiFlow, you don't have as much control because the device is just on the patient's eyes, and then the treatment takes place. But you don't have to do anything. You could have a front desk person hanging out with the patient during the treatment. So again, if there is less than 5 meibomian glands yielding a liquid secretion, we must do treatment on these patients to improve the gland flow. Well, Dave, why don't we just use warm compresses? Well, the reason why is for an eyelid to actually melt the oil, the inner eyelid temperature must be at least 104 degrees Fahrenheit. Outer eyelid temperature must reach 113 and stay there long enough for the heat to penetrate to the meibomian glands. Much of it is being taken away by the blood vessels. Much of it is absorbed by the tarsal plate and spread out. And an incredible amount of that heat is going into the cornea. What we need to do is get heat on the surface of the eye, hot enough, long enough to get at least to 40 degrees Celsius. Here was a study that looked at warm compresses, and you can see that none of them got up to 40 degrees. The one that did get the closest is called the bundle method, which is where you take 5 washcloths, you heat them up in the microwave, and then you put them on the patient's eyes for 2 minutes, and then you go and get the next washcloth. And that's been shown to be the most effective warm compress system that's out there, but it's very tedious and very few patients are going to actually do it. And then we talked a little bit about the do's too, reporting that it could improve things for patients on the neurosensory component. This is one of my team members who was volunteering to utilize the TrueTear device. And in just a moment here, you're going to start to see her eyes. There it is. She's starting to blink. She's starting to get the tears, and she is feeling that sensation. Well, TrueTear was up the nose. We now have another device from a Washington-based company called the iTear. We did the FDA trials on this particular device, but it is on the outside of the nose, and you just hold it here, right on the nerve, and it vibrates and stimulates, and it stimulates the tear secretions, and it also stimulates the meibomian gland secretions. And we see a very similar effect to the TrueTear device, but from the outside. So if you want more information about that, let me know, and I can introduce you to the founder of that company who during COVID, they got the FDA clearance. We were super excited to see that happen as being part of their trial. They got FDA clearance, and the device is now on the market, but it showed improvement in the tears for those patients. Now, the reality is that we have to identify dry eye disease, particularly for our contact lens wearers, because that is a desiccating stress. We have to identify, is there lacrimal dysfunction? We identify that by decreased tear volume, increased corneal conjunctival, any type of staining, and we identify that as being when there is inflammation. If those 3 things are present, quite simply put, that patient must be on a pharmaceutical agent to alter the lacrimal gland. Now, that's not the only thing that's out there, but that's the simplest way we start. On the meibomian gland dysfunction side, we realize that when an eyelid is blinking, it's releasing oil. If we can simulate that with something like a meibomian gland expressor, some of you use your thumb and jam it into the eye, and that's not really the equivalent of a blink. And if there's less than 5 meibomian glands yielding a liquid secretion, that patient must have a thermal pulsation treatment. Sometimes people think, well, maybe I'll just heat up the eyelids and then express or squeeze the meibomian glands out. Well, the reality is within seconds of taking heat off of the eye, we start to see the meibum start to harden again. And the amount of pressure you have to push for it to be therapeutically beneficial is quite substantial. So it may not be as therapeutically beneficial as something like LipiFlow or the iLux, which are 2 of the devices that from a literature standpoint, both and clinical, we are advocates of because we've seen improvement for patients. So come up with your protocol or call me up and see if we can find a way to help you with that, of whatever that is. So to kind of lay this out, our treatment is broken down into 4 categories. 1, we want to reduce the underlying cause. If that patient is in a monthly disposable and they're wearing lenses 6 weeks at a time, or they're utilizing a chemical solution, or they're in an older daily disposable, if we can get them to utilize an artificial tear throughout the day with their contact lenses, if we can get them into a better lens. From our scleral lens standpoint, we need to make sure we're putting HydroPeg on those lenses. We need to do what we can to keep the surface of that lens moist, teaching the patient to rub the lenses and so forth. So some really, really key components here about reducing the underlying cause, and also slowing the progression of the condition, enhance the surface homeostasis, and improve the comfort for our patients would be the next thing. I just want to pause for a moment. If you could all go over to the chat section, you're going to see a little link in the chat section. And it's at this time that we need you to go ahead and click on that link, and you'll be driven to a document where you can sign that you were part of the education. We needed you to stay to the end of the education and be here for the questions and answers. So look for this link, go ahead and click that, type in the information so that we can then send you a certificate. If you don't sign here, it means that you weren't part of the lecture during this portion, and we can't give you CE credit. So go ahead and click on that link. If for some reason it's not working, then let us know in the chat section. If it is working, would somebody just give me a little nod that it is working so that we know that you're able to go in there. When it comes to solutions, we want to eliminate the solution issue that patients are having if possible. So get rid of solutions altogether. Make sure patients are washing their hands, monitor the size of the lens, the sagittal depth, the base curve. And then we want to really work on modifying the material and getting them into a newer lens type, if at all possible. So with that, I will kind of close up the lecture here. Please stay on for the question and answers, as that's something that is important for the continuing education component here. And I do want to clarify and really end the lecture with a recap. That is kind of what I just said there, is if you're having patients with contact lens discomfort, it's so critical to become aggressive early on so that we don't see that 80% dropout in contact lens wearers that of the ones that do, but it being discomfort. We know that 1 in 5 are dropping out every single year. And in your practice, about 1/3 of all patients are contact lens wearers. And over the course of a 6-year period, they are 91% more profitable if they are wearing lenses versus spectacles. So both improving the quality of their life, but also improving the comfort for those patients and improving the bottom line in your practice. We want to improve things from a material standpoint by looking at that diameter chart that I showed you, but also improving the overall fit of the lenses and the replacement schedule, if at all possible. On the dry eye side of things, looking for lacrimal dysfunction, conjunctival corneal staining of any sort, inflammation, and also if there is an alteration in the tear volume. That signals that we need to put the patient on a medication and so forth. And also on the meibomian gland side, if there's fewer than 5 meibomian glands yielding liquid secretion, then behold, you have MGD. And something to get a gland to go from less flow to more flow is so critical. Now, people ask me, what about warm compresses? Why did you recommend warm compresses for everybody? Well, they've never been shown in literature to take a patient from no flow to more flow. But what they have really yield for us is that they improve the oil secretions. So we believe that when a gland is flowing, that warm compresses keep them flowing. So very critical as a maintenance thing for our contact lens wearers to keep doing that. So thank you so much, and we'll see you next time.